We're going to read through this article, and I hesitate to even call it an article because it's an opinion piece, but the important part of this is these three individuals that authored it. When we look at the HICPAC roster, we see that the co-chair is Wright, the second in command, who is also the first author of this article. Then we have Shenoy, one of the general members, and we have Hillary Babcock, who is one of the liaison representatives. Three people who penned an anti-mask against masking article published on April 18th, 2023, while they were a part of HICPAC, the committee that is tasked with setting the standards for masking in healthcare settings. So they believe that masking is only good in healthcare settings in the context where there is no population immunity, there's limited testing capacity, and there are no medical countermeasures like vaccines and therapeutics like Paxlovid. And since they believe that the pandemic has transitioned to endemicity, which it hasn't, it's still a pandemic, but because of that, they believe that we should reevaluate universal masking as a part of standard precautions. And this is for all direct patient care encounters, regardless of symptoms or diagnoses. So essentially what they're advocating for is no masks. We don't care what symptoms you have or what diagnoses you have. We don't think you should mask as a part of standard precautions in healthcare settings, ever. And this is their logic. They believe that masks directly interfered with healthcare workers' ability to deliver care. And their arguments are sort of fivefold. They think that people aren't dying anymore, so we shouldn't care about it, that we have wide access to therapeutics, that we have extensive immunity, improved vaccines, and widespread testing available, and that outside of this, masking marginally reduced the risk of transmission, that impedes communication, especially for people with English as a second language or who are hard of hearing and rely on lip reading for nonverbal and other nonverbal cues. And oh yeah, masks obscure facial expressions, so people can't see you smile. And this contributes to feelings of isolation and loneliness, and negatively impacts human connection, trust, and perception of empathy. So breaking all these down, this statement is demonstrably false. Masks significantly reduce the risk of transmission and are our number one source of transmission control. And outside of transmission control, they're the number one thing that will protect you from getting infected yourself. Masks do not impede communication whatsoever. You can speak through a mask. If so, how would surgeons do their jobs? For English as a second language, just have an interpreter. For people that rely on lip reading and other nonverbal cues, there are masks that exist with plastic over it so people can read lips. These are N95 quality masks, so if you're really concerned about that, you could get these types of masks and have these more expensive ones purchased for all hospital staff that directly deals with patients. In addition to, you could just have a sign language interpreter. And then we do not need to see facial expressions. This is a bunch of bullshit. And then I was so angry I skipped these two parts. So they're saying that there is substantial population level immunity that's providing durable protection against severe disease, and a series of less virulent variants and widespread availability of medical countermeasures. And they're also saying that COVID has transitioned to a more stable phase, during which the choice and intensity of mitigation efforts must be commensurate with the risk and align with management strategies for other endemic pathogens. So now we don't have substantial population level immunity because one, COVID impacts your immunity every time you get it. It decreases your T cell count, your B cell count, your ability to mount an immune response. In addition to, most people aren't up to date on their vaccines. They did not get the bivalent vaccine. There's only 15% of people as of today have gotten the XBB 1.5 COVID vaccine. People are still dying of COVID, so it's still a very severe disease, and we still don't fully understand it. And we know that it has long-term lasting complications, such as long COVID. And there's absolutely no evidence for the statement of a series of less virulent variants. And we are definitely not in a more stable phase. If we were stable, we would have seasonality. It would be predictable. COVID still isn't that predictable. This is our wastewater data for California. So in year one, we had a wide spread. In year two, we had the waves much closer and much longer than before, and now we're having COVID all year round. What about this is stable? It's becoming progressively worse over time. And for our medical countermeasures, like Paxlovid, those just got bumped up in price to $1,400 in the US. And because of Paxlovid rebound, which implies that the course of Paxlovid is not long enough for most COVID infections, it's not even a perfect therapeutic countermeasure. In addition, kids can't get Paxlovid. People under 96 pounds can't get Paxlovid. People with dairy allergies can't get Paxlovid. On top of all that, we have the insurance issues. So, no, there is not widespread availability of medical countermeasures. But they think we don't just want to get rid of universal masking policies. We want to dismantle everything. We want to get rid of asymptomatic testing. Nope. We want to get rid of resource-intensive contact tracing, so just contact tracing. So we don't care if people get infected and we know about it, and we could actually warn people so that they don't get infected and spread the disease to their loved ones and family and friends. And this sentence is hilarious. Why? Because they just said they want to dismantle all of our contact tracing and everything else, so how are we going to have frequent updates and regular reevaluation to be able to confirm that we need to scale up or scale down operations with masking? What would this be based off of, since you want to tear the whole thing down? And while the views in this paper are claimed to be those of the authors and don't necessarily represent those of the U.S. Department of Veterans Affairs or the U.S. federal government, it is important to note that the lead author is the second highest power on the HICPAC committee. These people that believe we don't need any mitigations in healthcare, specifically with masking, in addition to everything else, are directly influencing our recommendations and systematically weakened our rules and regulations, as I detailed in other videos.